Hi guys, welcome back to the channel if you're one of our regular viewers. If, however, this is your first time to the Prostate Clinic channel, welcome. Here we talk about all things related to men's health, in particular to talking about prostate conditions. We talk about where, what, why is the prostate, what can happen to the prostate as men progress through life, and some of the contemporary management strategies for how we deal with some of these situations. If this sounds like you, please enjoy. Leave some comments or questions down below. I do my best to get back to people so that this session can be interactive and we can all learn more about what we can do with regards aspects for prostate health. In today's video, I wanted to take a deeper dive into how we manage a PSA that increases after someone has had definitive therapy, in particular, surgery. The cornerstones of how we manage localized prostate cancer is either with an operation, which is called a radical prostatectomy, or alternatively with radiotherapy. There are pros and cons to those two different pathways, and I'm not going to get into those specifics in today's video. What I wanted to concentrate on more specifically is if someone has a radical prostatectomy for the management of their localized prostate cancer and their PSA increases pursuant to this, what does it mean? What do we do? What are your choices? Let's discuss. Okay, so to take a step backwards, when someone has a radical prostatectomy, at the time of surgery, their prostate is sent to the lab for final analysis. What we're looking at really in that final lab assessment is to get some specifics with regard to what type of cancer someone has. What we're looking for is how big is the cancer? What is the final Gleason score? Is the cancer contained within the prostate? Is there any extension to the shell or beyond? Is there any cancer at the edge of the resection? All of those pieces of information give us, as specialists, as urologists and healthcare providers, gives us information with regards, crudely speaking, on a scale of not aggressive to more aggressive. It gives us an idea of where someone sits on that scale. In particular, what it does is give us a risk of recurrence. Now, many people say to me, hang on a minute, Charles, you've taken my prostate out. If my prostate is gone, how can my prostate cancer recur? Well, the answer to that lies in the detail of what we see on that final lab test. When we have more aggressive features, there is a greater risk that a cancer cell can escape from someone's prostate, and that cancer cell can lay dormant for a period of time. But something can cause that cancer cell to become active, and when it does, it multiplies, and we see someone's PSA increase with time. Now, many men also say to me, and their family members, they say to me, well, hang on a minute, Charles, are you telling me that after surgery I need to continue to have a PSA test? And I say, yes, you do. And they say, well, hang on a minute. I thought the prostate produced PSA. You've removed my prostate. Why are we doing the blood test? You are correct. If someone has no prostate, the PSA should be 0. And that's exactly why we do it. Because if the PSA test is not 0 at any stage in the future, what it tells us is that there is a recurrent cancer cell, and that cancer cell can be multiplying. The probability that there is a rogue cancer cell that escapes from the prostate is intrinsically related to that final lab test. So, for example, larger tumors with a higher Gleason score, in particular 8s, 9s, or 10s. You may be aware from one of our previous videos that Gleason scores correlate with Gleason grading groups. In essence, the higher the grading group, so if someone has a grade 3, 4, or 5, if someone has a higher Gleason score, the probability that a cancer cell can escape and lay dormant to recur in due course is greater. In addition, the other characteristics that are important relate to some of the pre-surgical characteristics, and in particular, what's the PSA before someone has surgery? And there is a direct correlation between the elevation of PSA before someone has surgery and the probability of recurrence afterwards. not only the absolute value of PSA before surgery, but the kinetics or the rate of change of someone's PSA in the year before they have definitive therapy. That in and of itself correlates with the risk of recurrence. And that number is that if someone's PSA changes by 2.0 in the year before they're diagnosed, they are at a greater risk of having what's called biochemical recurrence, a change in the PSA, after they have definitive therapy. Okay, so someone has surgery, we get the final lab test, we know the crude criteria, the profile, the blueprint really of someone's disease. We then know the probability of whether or not we think they're going to recur. But more importantly than that, we get a risk profile of whether or not we think that man is likely to recur locally, i.e. in the area of where the prostate used to be, or whether we think that there's a greater probability of recurrence further afield. Okay, so if we look at the risk factors for local recurrence, the risk for that is greater if someone has cancer that has breached through the shell, if someone has cancer at the resection margin, or if there is extension of the cancer from the prostate into the attached seminal vesicles. So those are the three criteria that we really look at and hone in on to determine if those factors are present and that person experiences biochemical recurrence, an increase in PSA in due course, that man is at a greater risk of having local recurrence. The significance of determining this we'll get to later on in the video. If someone has no extension through the shell, a clear resection margin, no extension into the seminal vesicle, but they have a higher Gleason score, so a higher grade cancer, meaning that the cellular activity within that cancer is more aggressive, those people are at a greater risk of having what we call micrometastatic recurrence. Fancy term. Basically what it means is that they are less likely to recur locally and more likely to recur further away from where the prostate used to reside. Okay, so to recap on some of those characteristics, when someone has surgery, we get a blueprint of the behavior of their cancer. That predicts for us, do we think they're more or less likely to recur? In addition to that, it tells us, do we think they're more or less likely to recur locally or in a micrometastatic, further away from where the prostate used to be scenario? So following surgery, every man needs to undergo PSA surveillance. In my practice at the prostate clinic, they have a PSA initially at about 10 weeks after the operation. Now, the reason why we leave it a period of time from surgery to doing the PSA is because of something called the half-life of a PSA, which is roughly around 6 to 7 days. And it does take around 7 or so half-lives to fully wash the PSA out. So, for example, if someone had an operation today and a week later they had a PSA test, they'd still have PSA in their system. It does take a period of time for that PSA to wash out. So the first PSA we delay. As long as that PSA is 0, we usually just monitor the situation with periodic PSAs, 3 monthly for the first year, 6 monthly from year 2 to year 5, then annually thereafter. If that PSA increases at any stage, the first thing that we do is to go back to the final pathology to get the clues. Do we think that guy is at risk of local recurrence, or do we think he's at risk of disseminated recurrence? That is key because it directs our management. If we think someone has local recurrence, i.e. a cancer cell in the area of where their prostate used to be, we then have a discussion about salvage radiotherapy. Now, that man, if he experiences a single change in his PSA, does not require immediate radiotherapy. We do have time. And with the most recent data that we have, the cutoff point, the crude cutoff point about getting benefit from adding on salvage radiotherapy is that man needs to have or consider having radiotherapy by the time his PSA approaches 0.2. So with many laboratories, we actually get PSA values currently down to around 0.008. So we can detect a very, very low threshold of PSA. So if we see a change, we, to begin with, watch and monitor the PSA to determine if that PSA change is consistent. And if that PSA is consistent and we see subsequent rises, subsequent increases in the PSA, at a certain point, well before 0.2, we have a discussion about the utility, a discussion about adding on salvage radiotherapy, and if we think a particular man is going to get benefit from that. To recap again, he is likely to get benefit if he has disease through the shell, cancer at the resection margin, or extension into the seminal vesicle. So if those features are present, we have a discussion about salvage radiotherapy, and in my practice, consider an early referral through to a radiation oncologist to have that discussion. If the PSA goes up and there are none of those features, then the probability that that man has local recurrence is very low. And so we have a different strategy for managing that particular scenario. What we do in that situation really is to monitor the PSA until it gets to a threshold, at which point we think we can identify where a recurrence is. And so the way that we approach that really is continued sequential PSAs. We wait till the PSA gets to 0.2, and then we repeat a PSMA PET scan. Now, at a threshold of around 0.2, we will discover where the point of recurrence is in only about 20 to 30% of men. If we find where that recurrence is, then obviously we have a discussion about the details of where it is. Is it in a lymph node? Is it further afield? Is it perhaps a little spot in a bone? Is it, in fact, local recurrence? And so depending on where we find that spot guides us as to what our next treatment strategy is going to be. If, however, we don't find anything, then the pathway for that gentleman really is to continue monitoring his PSA with a view that at some stage in the future, we repeat the PSA and the PSMA PET scan again. Crudely speaking, the higher the PSA gets following surgery, the greater the probability at some stage we will have a positive PSMA PET scan. In my practice, I tend to repeat the PET scan again at a value of around 0.5, and if it's negative, again at around 1. The majority of people, we will pick something up at around 1, but a minority of men, we still will not find anything at that threshold point. Let me wrap up now by giving you some clinical scenarios of what we do in specific situations. Let's assume for a second we have a 65-year-old man who has a radical prostatectomy. His final pathology shows that he has a Gleason 7, a grade 2, a Gleason 3 plus 4 equals 7 cancer that had extension on his final lab test, extension of the cancer through the shell. That man, after his operation, had a 0 PSA. That PSA was 0 for a long period of time and then gradually began to increase around 5 years after his operation. That man, because of the extension of cancer through the shell, is at a greater risk of local recurrence. So for that gentleman, we would watch his PSA for 2, 3, 4 sequential PSAs, depending on the rate of change of his PSA, but roughly at a PSA of around 0.1, well below the threshold of 0.2, depending on how well he was at that stage, would consider referring that man through to a radiation oncologist to have a discussion about salvage radiotherapy. Let's take a different scenario. Let's say we have a 70-year-old man who was treated with a radical prostatectomy, and his final pathology showed a small Gleason 9, Gleason 4 plus 5 equals 9, Gleason grade 5 cancer, which was organ confined, no breach through the shell, and no cancer at the edge. That man has no risk of local recurrence. If his PSA increases at any stage in the future, we would watch his PSA until it hit a threshold of around 0.2 and consider then restaging, re-imaging his disease with a PSMA PET scan. Now, obviously, these two are just examples. These two scenarios are just examples of roughly how we manage the situation. Every man is different, and every pathological situation that we see is different and needs to be managed on its merits. I hope this provides some clarity of what we do with the PSA test following surgery. Please, if you get benefit from this video, consider subscribing, give the video a thumbs up, and please, as always, leave your story, leave your comments, leave your questions in the comments section below. I try to get back to everyone with regards to their questions and comments with this situation. I think we're building a really good community of men in this journey together. So please consider sharing your story. Thanks again. Until the next video, look after your prostate.